First set of pictures starting by Swasa. Hey, Venkat, are you there? So let's start with Venkat. Venkat, hey.
Yes, yes, I'm here.
Okay. Thanks for joining, Venkat. I know it's a very odd time for you. So without further ado, let's get this started. So as you know, we have 15 minutes for all these pictures, 10 minutes of presentation, and 5 minutes for Q&A. And
Sure.
give
I hope you can see my screen.
yes.
Okay, perfect. Hi, good afternoon, ladies and gentlemen. So our product is called Swasa, and we call it Respiratory Health Unbound. The reason for the tagline is something that's going to be evident. I mean, this is the template that was given, so I tried to follow the template as much as I could. So the problem we're trying to solve for is a pretty large and important one, and I would say that it's also been a neglected one for various reasons. So there are roughly 550 million people worldwide who are afflicted by the big five respiratory diseases. 1 in 8 deaths are because of respiratory diseases. 7 million deaths, are caused by respiratory. Right? You catch the people with the problems early, you diagnose them early, and then you monitor them, especially the chronic conditions, over time. Right? So what exactly do we deliver, through our solution? So we basically are able to deliver a a solution that can be operated by literally anybody. It's accessible anywhere, anytime. There is no need for special hardware or software or or trained technicians, consumables, none of that. Um, the results are available in near real time, and it's super inexpensive. And what we have there is a placeholder, and we are driving the costs even lower, and it's scalable. Now, when I say we are driving the cost lower, the main comparative for us is spirometry, which is $1,000 to $1,200 in the US. And so that's what you're benchmarking the 15 cents against, and then we think we can drive it even lower, right? Um, and also the other thing is both the patient as well as the physician don't have to be in the same place at the same time, so they can be completely separated by both time and space. So the main thing is traditionally spirometry, which is used to assess lung health, is bound by location. You need special equipment, which is expensive. You're bound by time, and the most important thing is you need a really trained technician. So as you try to scale it up and take it to places where it doesn't exist, then all of these are constraints. And so what our solution does is it makes sure that it breaks free of all these constraints. And added to that, it takes it down, that takes the cost down 1,000-fold or more. So that's really what we're doing. So how does our system work? We basically operate on cough sounds. We do an audiometric analysis of the cough sounds, and we use a subset of the St. George's Respiratory Questionnaire, and both of them together run through our AI platform, which we call Swasa. And on the top, what you see is basically the inferences that are drawn from the volume and the flow graphs of a traditional spirometry, right? In addition to that, we give you some quantitative data and qualitative data. We are at the preliminary stages of being able to classify and identify various disease pathologies. And so this is where we are. While I've made comparisons to spirometry, the main the power of what we bring to the table is not just that we've got a cheaper way of doing an assessment of the lungs. The way I can illustrate it is, if you have a scheduled spirometry assessment, let's say on a Saturday, what the physician has is a one-time snapshot view of the patient's lungs. But given the way we are implemented, where it can be done anywhere, anytime, using a mobile phone, laptop, whatever, right, any device. So the patient is, for example, able to do self-assessment. any number of times during the week. What it does is it provides a really nice longitudinal view of what's happening to the patient's health in near real time to the physician. So this is certainly a very powerful tool for the doctor to use with all the rich data that comes along with it. We extract a lot of features, and we track a lot of the features. But broadly, one of the things that we can do, because we are no longer looking at one assessment in a year or one assessment in 6 months, but you could be doing 50 assessments in a week, is you have a cluster of data points which allow you to both threshold as well as trend line the various parameters, and then this allows you to then send alerts proactively to both the patient and the physician. This is what a typical chart looks like. As soon as the physician signs in or the physician assistant signs in, all the patients are classified by risk, and then you can get down to whatever level of detail that you want. You can keep drilling down. And behind each of these points that you see on the screen here is a detailed report, which is essentially a spirometry report, and the equivalent of a spirometry report. And then, so you basically have all those reports available at the lowest level of the drill down. So how does it compare with all the existing tests? Basically, it's the simplest, easiest, no risk kind of assessment for respiratory health. So that's really where we stand. The API integration that we currently have is really simple. The inputs that we need are only the questionnaire that we talked about and the cough sample, and we are able to process it and send back a response using our APIs. So there's more detail here. So the technology itself has been 5 years in the making. We are right now, we are already commercially launched in India. We have the regulatory approvals in India. We have a lot of patents. We have patents in multiple geographies and publications and awards to back up all our work over the past 5 years. So we are, by the way, we are also HIPAA compliant as well as ISO 27001 compliant. We also recently got our SOC 2 certification. So we take care of all the data privacy and security aspects. And so we are ready for commercial launch.
Hey, Venkat,
with that, my presentation is done. Yeah.
Thanks, Venkat. I appreciate your time, and it was a well on time. And I think it's a very, very useful and timely application. And we are excited to work with you. And let's open up the floor for the judges to ask you any questions. Judges, do we have any questions for Venkat?
This is Jill. What is the age range? Because I work primarily with kids. But with asthma, this would be something handy for a parent. How can that be adapted for them?
That's a great question. So one of the things, obviously, there are lots of things I didn't talk about. One of the things is we have conducted clinical trials, and we are currently approved for adults. Clinical trials for kids is really one of the things that is on the agenda, but we haven't got it done yet. We are currently running a whole variety of clinical trials in multiple locations, but kids isn't one of those yet. But that's definitely one of the things on our agenda.
So is this meant for doctors' offices that want to monitor, like do remote patient monitoring? Is that what this is going to be used for?
Interesting. So there are multiple use cases. One of the use cases that it's currently being deployed in is remote assessment and screening in low resource settings. So basically, it's being deployed in a rural health setting in India as we speak in two different states. And what it is so you want to catch, for example, tuberculosis is a huge problem. So you want to be able to find out if there is any chance of risk in populations where they probably have to spend a day and travel a few hundred miles or kilometers to just get to a physician, right? So this is one of the use cases. The other big use case, as I mentioned, is monitoring, right? So once someone's diagnosed with a condition, particularly things like COPD or asthma, and one of the studies we are doing also is, are there patterns that we can detect that that can give you a warning about onset of exacerbations and things like that. The third use case, of course, is it's a quick and dirty check. One of the pulmonologists in Kansas City said, I wish I had this tool many years ago handy in my office, so I could quickly use it on my patients. So that is one of the use cases as well.
So I think there are no more questions here. If you guys have any questions, you can chat or connect with Venkat on LinkedIn. He's pretty active lately. So thanks again, Venkat. We'll talk to you soon.
Yeah, thank you so much, ladies and gentlemen. Thanks for the opportunity to talk to you, and then look forward to engaging with you later. Bye.
Bye. Yeah, the next speaker we have is Telehealth. Alan Young from Telehealth is going to talk. Alan, if you're ready, let's start the presentation, please.
Yes, good afternoon, everyone. Let me just get my presentation up and we can get started. Can everyone see my first slide?
No, I can see it, Alan.
Is it not sharing?
No, I can't see it. Anyone?
Let's try again.
Okay. Take your time.
Is that any better?
No.
I feel what you're sharing is not what is on top of your desktop.
Got it. All right.
So it's dark for us.
Let's do this then. Is that better?
Still dark. Meaning it says you're sharing, but we see only a dark screen, or at least I see a dark screen.
Okay. Let's see here.
So are you on a phone perhaps, or are you on a Mac or a PC?
I'm on a Mac. Normally this has no issues, but let's try this way.
Okay. Yeah, I think it's just a multiple desktop situation with your Mac. I think you're sharing a desktop that is not where maybe things like that, something like that is what is happening. So
how about now?
No, same thing.
Okay.
So let's try our Sage, can you load up his presentation and we can flip it?
Sure, yeah.
Okay.
Let me pull that up.
Hang on a second, Alan.
There you go.
All right. Well, good afternoon, everyone. Thanks again for taking time on a weekend to be here with the CharmHealth Innovation Challenge. My name is Alan Young, the head of clinical partnerships with Telehealth. Can we go to the next slide? Today, I'm going to quickly talk about Telehealth and our platform, the data and technical integration requirements that we use with our clients, the customers that we're working with, and then end it with some Q&A. Next slide. So Telehealth is a team comprised of physicians, surgeons, data scientists, engineers. This company itself originated out of Duke Health, where a number of physicians realized there's an opportunity to leverage the big data captured within the electronic health record to really improve the area of surgery. Next slide. And our focus has really been on all 4 quadrants of the quadruple aim, really looking to improve patient experience by helping with how we can capture patient growth using a digital engagement strategy. We improve clinician experience by embedding our software into the workflows currently within their EHR. As a result, we can improve and apply clinical decision support to lead to better outcomes, fewer complications, and as a result, lower costs across the whole system. Next slide. So our view of the future of surgery, the problem is fairly big. In the United States, there's almost $77 billion worth of cost attributed to preventable complications in surgery. There's about 50 million procedures done per year pre-COVID. And with the pandemic slowly starting to come under control, we see a surge in procedures, especially elective procedures, being done both in the inpatient and outpatient setting. So we feel that Kilo Health is well positioned to provide a data that's going to be adaptable across multiple subspecialties and eventually, adopted by surgeons and their teams that can be scaled across multiple locations. Next slide. And we achieve this by a deeply integrated software as a service, a machine learning platform, where we identify early warning signs of potential complications based on all of the data we ingest from various sources, including the electronic health record. We tie these interventions or risk predictions to clinical actions or interventions that the surgical team can decide to help reduce the risk or mitigate the risk, and also help them make decisions as to where and when to have a surgery. The biggest ask from our clients recently is they're trying to move a lot of procedures from the inpatient setting to the outpatient setting. And historically, patients have had surgery within the hospital to be in the safest environment possible. But history shows us and evidence can tell us which surgeries can actually benefit or actually do just as well in an outpatient setting. And that's become more and more important in the post-pandemic world. Next slide. So our intelligence platform really takes personalized risk for each patient based on a large data set that we've trained on over 4 million surgical patients in the past from sources such as the NISQIP surgical database. We provide optimized action recommendations to the clinical teams embedded within their electronic health record. And we track patient outcomes as they move forward to ensure that our machine learning algorithms continue to learn and iterate as we move forward. Next slide. So our data we ingest comprises of a number of clinical inputs. For each patient, we can assess up to 200 different discrete data elements, including demographics, medical history, diagnoses, medications, labs. We produce predictions based on 12 outcome categories, including wound complications, cardiac complications, respiratory complications, et cetera, and can also predict for readmission, reoperation, and mortality rates. These tie very nicely with current programs that assess hospitals and their surgical care quality, including hospital-acquired conditions, patient safety indicators, and readmission reduction program. We also have received a lot of interest from folks that are looking at bundled payment programs for different subspecialties, including orthopedics and cardiac. Next slide. So with Kilo Health, we're there as part of the surgical journey. From the time a patient has initial consultation, in this case, for a knee replacement, we integrate into the EHR and give the surgical team a risk assessment initially. The surgical team can then decide if there's any interventions warranted, such as weight loss, smoking cessation, repeating labs, and physical therapy. And that provides the clinical decision support tool that updates the risk scores and allows the patient then to have a surgery at the right time, at the right place, and in the right setting. Next slide. We do this by notifying the surgical teams through a secure email communications. Next slide. We're embedded within the HR. In this case, we have a display within Epic itself. So clinical teams don't have to leave Epic. They can access our risk and readmission recommendations as well. Next slide. We provide data visualization for the insights we provide and allow a risk score to be analyzed deeper to look at all the different factors that actually contribute to that risk. Next slide. And we provide seamless integration. We have a cloud-based SaaS platform that's HIPAA compliant, and we ingest information from the health system and their data lake or data depositories. We run our machine learning algorithms using ensemble machine learning, and then we also do transfer learning, which we'll talk about, to increase the accuracy of our model. And then we integrate back into the health system either through their EHR, a web app, or a mobile device. And this is where we think CharmHealth could really help us identify possible synergies by working to kind of smooth the interface between us and our customers. Next slide. We've harnessed the power of data science to really, take all of the surgical data that's available to us to generate a generic kind of national surgical risk model. Next slide. We then tailor the model according to the local hospital or surgical data in a method called transfer learning that helps to increase the accuracy of our models. Because no two surgeons and no two patients are the same. We definitely want to use our model based on the client or customer's data and look at their historical information in conjunction with the larger data set that we're able to obtain through our work at various health systems. Next slide. The results speak for themselves. We've noticed across different specialty cases we've been working with over the last year, reduction in readmissions, large reduction in surgical site infections, a better ability to identify acute kidney injury, and overall reduction of costs ranging anywhere from 26 to 50%. Next slide. The biggest thing is really the surgical teams are engaged with this process. We fit into their workflow. We kind of do the work of reviewing all of the data within an electronic health record. We surface interventions, risk predictions, and recommendations to them, and they ultimately make decisions kind of in the flow of what they are used to doing. So we will send an email to them on the day of their pre-op clinic or day of surgery or after the patient's been discharged. We will also be there as part of their EMR, and we can access the information available to their patients and surface it to them in a dashboard. Next slide. Thank you for your patience. I apologize that this presentation did not go as smoothly as I planned, but happy to answer any questions.
Thank you, Alan. Thanks for your time and appreciate it. It was a good presentation and you ran through very well. So we have 5 minutes for Q&A. And judges, please ask any questions you have before voting.
This is Jill. You mentioned Epic. What other hospital-based EHRs are you working with at this point?
Our first initial clients have both been on Epic. We also work with a private ambulatory surgery clinic that has their own homegrown EMR. So our team is capable for integrating across kind of every EHR available. But that's one of the appeals that we have with working with CharmHealth is that their experience here may benefit us as we work with other EHRs, including Cerner and other more popular ones.
Hey, this is Vinky here again. Are you guys looking to raise funding now, or what's the situation?
Yeah, great question. Sorry, I skipped that over as one of my slides. So we were fortunate enough during the pandemic to raise a seed round. Some of our prominent investors include Intuitive Surgical and Sante. And at the end of 2021, we plan to open up a Series A where we're seeking maybe a couple of strategic investors to help fill out our round. But we plan to probably raise a total of 12 to 15 million at the end of this year. We have about 12 million of that committed already.
Okay, there's a question from Dr. Shubhra Jain. She wants to know how many customers do you have now and what's your sales cycle, typical sales cycle?
Great question. We're currently deployed across 3 customers. Our sales cycle involves, working with kind of channel partners as well as the leaders across organizations. Typical health systems, software as a service, sales cycles could be anywhere from 6 to 18 months. We've been fortunate enough to really accelerate that through some of our channel partners, and we hope to close probably another, 4 to 8 deals at the end of this year.
Okay, I think that's about it. I think there are no more questions now, but you can continue to chat with our judges on the side. Thanks again for your time. Appreciate it.
Thank you, everyone. Have a great day.
Thank you. Our next presenter is from DeepScribe.
Hi, everybody. Give me a second while I pull up the presentation. Hopefully this goes smoother.
Thanks for joining DeepScribe. DeepScribe is a very interesting company while Matt is trying to pull up and get ready. Yeah, I think he's ready. So let's start, Matt. Go ahead.
You guys can see it?
Yeah.
Okay, great. I'm lucky today. So hi, everybody. Thanks for being here. My name is Matt, and I'm one of the co-founders of DeepScribe. And at DeepScribe, our mission is to bring the joy of care back to medicine. So I want to start off today by introducing you guys to one of our early customers, Mark. Mark is a 61-year-old primary care physician, and he's been practicing medicine for over 30 years. And this is a report card given to him by his wife, Nancy. And as you can see, he's not doing too well. He has an F in dinner attendance, a D in listening skills, and a C with spending time with his kids. Now, you may look at Mark and say, you know, Mark looks like a pretty nice guy. What's going on here? Well, the truth is that doctors are becoming clerks, spending nearly 40% of their day on documentation alone. And as a result of this, everybody loses. You have the joy of care that's being ripped from our physicians, leading to dangerous levels of physician burnout. You have healthcare systems and healthcare organizations that are extremely challenged because you have a high-skilled worker spending nearly 40% of their day doing a relatively low-skilled job. And finally, you have patients that are unsatisfied, leaving them with only about 1.5 minutes of direct physician face time in the average appointment. Now this is not a new problem at all. Around 80% of doctors today use some sort of documentation tool. Most physicians today use transcription or a dictation service because these tools are extremely accessible and they're extremely affordable. However, when you talk to them, you find that these tools tend to be pretty ineffective because they simply lift the burden of typing and not the burden of the documentation itself. And because of this, this really gave birth to a new market of tools, which around 10% of doctors today use, which are virtual or human medical scribes. Now doctors love these solutions because they truly lift the burden of documentation. But only 10% of doctors use them because these tools come at a very prohibitive price point. Scribes can cost anywhere from $20,000 to $50,000 a year just to have somebody follow you around and write your notes for you. And that's not to mention the training, the attrition, the scheduling, and all the other overhead that you have from adding somebody into that clinical workflow. And then you're starting to see this new category of these AI medical voice assistants. But what we found is that these tools also tend to be problematic as a lot of them require the physician to augment their workflows in some sort of way in order to accommodate for some of the technology shortcomings. So when we built this product, we really started with our users. We've interviewed hundreds and hundreds of physicians, and what we found is that when evaluating a documentation tool, physicians are really looking for 4 things. They're looking for an ambient scribe solution that is bespoke, that is accessible, and that is reliable. They want a tool that is ambient because only through an ambient tool will something like this not obstruct their current workflow that they've so carefully designed and grown accustomed to. They want something that's bespoke because every single doctor is different and they all have their own note preferences. And without the ability to really accommodate for these preferences, these doctors end up having to do a lot of corrections to really get it right or make the notes look like theirs. Next, they want something that's accessible, and they want something that's accessible from multiple dimensions. So they want something that's affordable, they want something that's portable, but most importantly, they want something that's available. So they want something that is, there for their specific specialty, for their specific EHR. And finally, they're looking for something that's reliable because, let's be honest, these physicians don't have time for troubleshooting, right? The downside of flawed notes, the downside of unreliable turnaround time and inintuitive products quickly eats away at the time savings that these tools have for their physicians. So after spending a nearly year and a half at the Berkeley AI Research Lab, we have developed a fully ambient AI-powered medical scribe that can produce comprehensive clinical notes simply by listening to the natural patient encounter. The difference with DeepScribe is that we truly offer the experience of a human medical scribe, but we do so at the accessibility and the scalability of a dictation tool. So we're through our technology, we're truly able to offer this ambient workflow, which means no wake words, no repeating what the patient said, and no summarizing. So let me just show you a little bit about how this works. So right here, this is just a natural patient conversation. And you see on the left, you see the transcription. And in that transcription, you see the AI at work, highlighting all the medically relevant concepts in that conversation. And on the right, you see how these concepts are then classified into a discrete section inside the patient's chart and summarized into a sentence that the physician would have otherwise written. So you can see here that DeepScribe intelligently listens to the natural patient encounter, right? And we're really emulating what a scribe actually does. And once these notes are completely finished, we upload them directly into the EHR, where the physician will then review and edit the notes and sign off as they normally do. And today, we are proud to announce that we have launched our integration with CharmHealth. So not only do we have the ability to sync the patient schedule, but most importantly, we're able to seamlessly push discrete sections of these notes into the charts in CharmHealth. So we're super excited to partner with CharmHealth to deliver this integrations to our users who are already on the platform and to any new user that is on this call listening right now. So with this differentiated product, we've also been able to bring a really unique value to our users as well. So we've been able to show that we can save physicians up to 3 hours per day on their documentation. That's 3 hours. And a lot of the time, our physicians are using this time to see more patients. We have a lot of physicians on our platform that are seeing up to 5 additional patients every single week. But to be honest, most of our physicians are using this time to simply spend on life. So one of my proudest moments at DeepScribe was when Mark's wife, Nancy, actually sent us this thank you card, thanking us for restoring the balance into their life. Now Mark is finally able to get home on dinner on time. He's able to go work out and really spend time with his family. He just has 2 brand new granddaughters. So now, going back to the report card, Mark is doing pretty well now. So he's showing up on dinner, he's listening, he's spending time with his kids. So we have not only been able to deliver this solution to Mark, but we've been able to deliver this solution to over 300 physicians in America who are using DeepScribe every single day for their clinical documentation. We've also been able to prove that patients are also comfortable with this technology and comfortable with having their conversations recorded with our over 98% patient engagement rate. So today, we are currently processing over 10,000 real life natural patient encounters every single week. But this is just the beginning. So with our technology, for the first time ever, we are able to ambiently structure unstructured data at the point of care, which we believe opens up an entire world of possibilities across the healthcare delivery continuum. We believe that our technology is kind of the foundation for the tech stack of the future of medicine, because although you see this amazing work that's being done on clinical decision support or back office management, these tools are relying on data that is being inputted by these clinicians into this EHR. And in the field of AI, we have the saying where you say, you put garbage in, you're going to get garbage out, and bad data leads to bad models. So we truly believe that, without the ability to eliminate the burden of documentation for these people that are entering the data into the EHR, we may never be able to realize the full potential of some of the amazing work that's being done in medicine today. So who are we? So we are, at its core, we're a team of deep technologists from some of the top AI labs in the world. And we're working with experienced clinicians and healthcare executives from some of the top healthcare institutions in the world as well. And we've all come together to bring the joy of care back to medicine. So thank you guys so much. If you want, you can contact us at founders@deepscribe.tech. And thank you for everyone on the call for taking time out of your weekend to listen to our story.
Matt, excuse me. Thanks, Matt, for your time. I think it's well done. I think the long time ago when we started talking about it and where you have come, I think it's a tremendous opportunity for everyone, especially the doctors who are here. I think they can really appreciate what you are showing them. And I think there are a bunch of doctors on the judges panel today, so I'll let them ask you questions.
Thanks,
judges, please. Yeah, go ahead, judges, please.
I liked Dr. Bassey's question. How much time on average do the physician users spend reviewing, proofreading, editing the notes after?
That's a great question. So it really depends, right? So it really depends on really two things. Number one, how well the physician needs their note to look like theirs. So for example, you have physicians that are very particular about what is included in the plan, or very particular about the way that it's structured. And one of the things that we've been able to develop at DeepScribe is this huge suite of customizations that allow these physicians to get a note that looks like theirs. But at the end of the day, there are still edge cases there where the physician then needs to go in and edit. On the other hand, you have physicians that need to include things that are not really said in the conversation. So we see this a lot in psychiatry or other types of more sensitive conversations where you don't really want to say everything that you need in the documentation to that patient. Where on the other hand, we have some physicians that are barely making any corrections to their notes. I would say less than one correction before they actually sign off on the note into the chart. So it really depends on the physician, on the workflow, and how they like their notes.
Hey, Matt, there are a few more questions on the chat, and one from Pramila here is, are you able to train the system on specific templates used by the physician, or can you customize it for specialty?
Exactly. So I think that's one of the things where our product really shines. So as I said earlier, we have this conversion layer that is able to ingest and accommodate for some of the note preferences that these physicians want. So these customizations include things from templates and macros that the physicians already have into their chart. So, for the physical exam, they would say the patient, tell a patient, hey, your lungs sound normal. But in the note, we would put, lungs cleared to acetation bilaterally, normal breathing sounds, et cetera, et cetera. But then we also have, other types of customizations that are a little bit more nuanced. So, we find some physicians like very verbose notes and really long drawn out sentences. So we've been actually able to build tools that we're able to adjust the verbosity of the sentences as well. We have different things like if you wanted to change your plan that's sorted by problem rather than narrative, we can do that as well. So the answer is yes.
And there are a few more questions too on the chat, if you can.
Sure, I can't see the chat. Thank you.
Yeah, no, let me read it for you. It's from Shubhra
Okay.
Jain, and she wants to know, are the notes available instantaneously, or how long do we need to wait? And we are moving to a team-based care, so how does these notes will work or reflect here in these situations?
That's a great question, Shubha, and good to see you again. So the answer is we have, there is a latency with the notes. So right now it's about 2 to 3 times the length of the conversation latency. So if you have a 5-minute conversation, it'll take anywhere from 10 to 15 minutes to push back directly into the EHR. But, and the question about the team-based care, we've actually are able to accommodate these types of workflows through our multiple recording feature. So one of the things that we've been able to do is physicians or MAs or anybody that's part of the clinical workflow can submit a recording for that patient. So we have, workflows where the MA goes in and records their conversation with the patient, usually to gather the history. And then the physician comes in, will record another conversation with the patient and get some of the physical exam stuff done, say their assessment, and say their plan. And then we would push, the patient would then go to a care coordinator or patient advocate. And then they're able to kind of record that conversation. And at the end of the day, we'll take those 3 recordings and synthesize what is being said into a single note.
Great. There are a couple of more questions here. One is from Alan Young, and he wants to know what NLP methodology do you use and analyze the data?
So there's a lot of stuff that we've built that I'm not sure if we can share necessarily, but essentially there's 2 areas that we've really been able to innovate here. Number 1 is our speech-to-text engine. So we've been able to build our own speech-to-text engine where, based off of our test, has been able to outperform, every single speech-to-text engine that we've tested, including IBM Watson, AWS Transcribe, the Google's video model. We're able to outperform these models in medical conversations. And the second piece is really the name entity recognition. So being able to identify what is considered relevant in a natural conversation and pull out and understand the context behind some of these conversations.
Hey, we got time for 1 or 2 more questions. So the next one from Jay, and he wants to know what is your revenue model, and if you can tell us about your current revenue run rate, and what are you looking to raise? Are you looking to raise money? And last time I talked to you, I don't think you said you don't want money anymore, right?
So we are a SaaS-based business. So we charge physicians a monthly fee to gain access to our platform. It's all license-based as well. So every physician has their own license for the platform. I don't know if I can share our revenue numbers right now, but we have over 300 physicians that are paying anywhere between $500 to $1,000 every single month on their documentation for the service. And we have a list of a waiting list in a lot of different specialties that we haven't launched to yet. So in terms of fundraising, we actually closed around in December of 2020, but we're not actively raising currently, but we're going to go to market to raise our Series A sometime in the summer.
Okay, one more last question for you is from Raymond Harjo, wants to know how does it work for telehealth visits?
That's a great question. So when the pandemic started, we actually developed our own telemedicine platform. So today we have the ability to host a web conference for a patient and a physician. And through that web conference, we're able to record that conversation and then generate the note for them. Another cool thing about our telemedicine solution is it accommodates for that team-based care that Shubhra was mentioning earlier. So, one of the things that we have is a virtual check-in process. So the patient can come in and go and talk to the front desk, and then in our platform, that patient is able to be handed off to the MA or the first person that they're going to go see after they check in, and then the patient can then be handed off to throughout the entire team for their entire care delivery. So we're able to accommodate for telemedicine not only through our own portals, but we can also integrate with other portals out there. So Zoom or Doxy or other preferred telemedicine providers that they're using today.
All right. Thanks for your time again, Matt. I think it was very interesting, and I think a lot of valuable piece of information. I think it's a very useful tool for the doctors, especially a lot of our judges are using. So I think if you hang around a little bit and answer any questions they may have, that would be good.
Okay. All right. Thanks, Banky. And we're super excited for the integration that we developed. And thank you guys all again for putting this event together. It's amazing. And thank you to the engineering team that has helped us work on the integration as well.
Thank you. So the next speaker is Dr. Sue of Ipil. Dr. Sue.
Hi, let me get started.
Again, just while you're queuing up the presentation, it's a 10-minute presentation and followed by 5 minutes
Sure.
Thank you.
Okay, well, thank you for having me. I want to thank CharmHealth Innovations for allowing me to present the Ipil. I'm Dr. John Su, CEO and co-founder. I practice anesthesia and chronic pain management for 28 years, and I've seen how addiction and pain and opioid use disorder has affected my patients' lives. Treatment is difficult, so I'm sure everyone has gone through this. When I tried to wean a couple patients off their opioids, they actually threatened me with a bad Yelp review. They threatened to go to the administration, and one person actually threatened me and my family. So I'm in a pretty difficult field to deal with patients. I want to ask the audience a question. Have you locked up your opioids today? And the important reason for that is because 128 people die from an opioid overdose per day. And that includes 1 in 4 opioid overdoses that involves children and teens. So, it's really the important consideration is that everyone has a solution for the opioid crisis, but no one's really looking at the problem. The DEA considers the pharmacy the end user of opioids. So the problem with opioids really starts in the home. In hospitals, opioids are locked in safes. These same opioids are sent home with patients and are not locked up. 73% of teens start abusing opioids obtained from their own house, and it leads to a couple things. Abuse, sharing, addiction, and overdose. The solution is to have a secure dispenser at home. This is to prevent unauthorized access to opioids, so only the person prescribed can access at only the prescribed dose and time. We also dispose of unused opioids so they cannot be abused or diverted later. Our product is the Ipil, a combined dispenser and app. The Ipil dispenser is a drug vault that securely stores pills. If tampering occurs, the pills are destroyed. Unused opioids are automatically destroyed in the dispenser itself at the prescription endpoint. The Ipil app is a biometric key that operates the Ipil dispenser, so only the person prescribed gets access. This can easily reduce abuse and sharing. The Ipil consists of 3 moving parts. It's simple to manufacture. It looks complicated, but it really isn't complicated. We have 3 granted patents and 3 PCT patents for Canada, EU, and the UK. Canada, per capita, has a worse problem than the US for opioid use disorder. Our Ipil product is an FDA Class 1 510(k) exempt device. It consists of the Ipil app and the dispenser. Our future product includes an Ipil Class 2 device that is an FDA designated breakthrough product. It consists of an Ipil app, dispenser, and respiratory biosensor. The respiratory biosensor is to detect opioid-induced respiratory depression. It will then determine access to the opioids from the Ipil dispenser and then call 911. The market for secure dispensing of addictive drugs is quite big. We decided to focus on the opioid segment because it has the highest overdose death rate. The value proposition of the Ipil is to reduce costs and improve care. We can reduce costs associated with opioid use disorder and reduce relapse rates in the transition from inpatient to outpatient therapy. Our market, we are selling to 2 market verticals, dental practices. This is where the first exposure of opioids to teens, and we can close a gateway to prevent a lifetime of opioid overdose, crime, unemployment, homelessness, and death. Addiction treatment centers, they want to reduce the reported 91% relapse rate and the cost of transportation to and from Suboxone and methadone clinics. The Ipil has traction already. We have a consortium of 320 dental practices that would like to trial the Ipil. This represents $4 million in annual sales. Dentists remove 10 million wisdom teeth per year, so we have a ways to go. We have 2 addiction treatment centers that have agreed to purchase the Ipil. This represents $7.7 million in annual sales. There are 14,500 addiction treatment centers in the US. The addiction clinics have agreed to pay $50 per unit for the Ipil. At 1% penetration, we have $64 million in annual revenue. At a 5% market penetration, we have a $320 million revenue model. Our production cost is $15, and that's with Foxconn, the makers of the Ipil. Sorry, makers of the iPhone. The Ipil offers more features at less cost. I think we're better than the competitors. We offer biometric authentication for active control dispensing, destruction of pills with tampering and at prescription end, and collection of data so we can have medication adherence monitoring. And that's one of the most difficult parts of my practice. The future of the Ipil looks good. The Ipil Class 2 is an FDA designated breakthrough product, so it will be the only dispenser covered by insurance. And we know this is true because CMS announced on January 12, 2021, that they are going to cover reimbursement of all FDA designated products via the MCIT program. That means that Medicare and Medicaid patients will be able to get access to opioids safely. This is important because recent studies have shown reductions in opioid access has increased opioid overdose deaths because patients are moving to illicit opioids. And it also leaves chronic pain patients in pain. And we really want to treat those patients. We are looking for $1 million to produce the Ipil and start human factor studies that we hope to start in Q3 of 2021. We will be looking for $2 million in the future to scale the product for an 18-month runway. The senior management team has startup experience. Everyone on the slide, the 5 people, has started 1 or 2 different startups. We all have exits as well. We're supported by a strong board. We're supported by advisors and vendors, which include a former FDA director, Foxconn, the makers of the iPhone, and 1 addiction clinic. Thank you very much for allowing me to present, and I'm open to questions.
Thank you, Dr. Su. I think we have a few questions here. Thanks for your nice presentation. I think it's a very timely and useful app. Couple of questions here. I think we talked about it even on Clubhouse. That's similar to that same follow-up question. How does the caregiver handle this? And similar questions like how does the caregivers can handle this, because this is tied to a particular patient or something. There may be a bunch of same caregiver will be assisting multiple patients. How does this going to work?
Well, it's really for the home. So right now we don't want to, our major focus is with behavioral treatment centers. So that means that we're trying to make sure this is for the outpatient situation for the patient's home. For a physician would, for instance, write a prescription for the opioid and ask for the Ipil to be associated with it.
Okay. And there are a couple of other questions still here along the same topic. So have you considered a large form factor to lock up dangerous drugs from kids? Are you working in how to prevent kids from accessing drugs from parents and others in the home?
Yeah, this is exactly what we're doing, because we just recently won a Flex grant from the CTIP, which is part of the Children's Hospital of Los Angeles. This is exactly the reason why we're doing the product, to prevent other patients, to prevent other household members from getting access. You have to use your phone to access the device. The phone is here. This is the device. It's about this big. and you have to use your fingerprint or face print and a personal code. That means that, you know, a kid who uses a fingerprint won't be able to figure out the personal code, or vice versa. The destruction mechanism looks like this. It's a DEA-approved solution that actually destroys the pills first, and then we encapsulate the remaining solution in a hard resin.
Okay, thank you. You answered a couple of other questions too. So that's the other questions. And another one was logistics wise. How do you get the refills here? Do they need to get it?
You know, the Drug Supply Chain Securities Act, anything that touches an opioid needs to be thrown away. That's why this device is inexpensive. It's thrown away in the trash can. There's no toxic materials. It complies with RCRA laws, and it's single use only. Again, has to be single use to comply with FDA regulations. So a couple of other questions here is, can you talk about your run rate now, revenue run rate now? So right now we have 2 purchase orders. We need to produce product and then get the human factor studies done. These human factor studies are going to be done in Connecticut and West Virginia. After we do that, we've actually spoken to Becton Dickinson, who actually own the Pyxis device. They have talked about OEMing our product or rebranding our product under their name so that they can extend their business plan from the hospital Pyxis to the home Pyxis device.
So how much does it add to the cost of the prescription?
Well, right now, our market cost is estimated to be $50. That's what the device is estimated to cost. That's what the addiction treatment centers. With the CMS covering insurance, we feel that this is going to be covered by insurance by Medicare and Medicaid. So we're trying to reduce the cost of patients. Our cost of goods right now is very low, so we can actually drop the price from $50 to much lower because it should be covered by insurance.
So the final question is a very practical question. What happens if the phone dies?
You're going to have to get your opioids at the ER. And I tell you, that's why we're using most people's own phones, because that means that, you know, most people can't live without a phone, and they're going to make sure it's charged.
Okay, that's a good answer here. Thanks.
Sure.
Thank you very much. Yeah. Judges, do you have any more questions? Or if not, we'll close this session with Dr. Su, and then we'll move to the next session. And Dr. Su, thanks for your time again. Please stay and chat with our judges and attendees.
Thank you.
Yeah, the next presenter is from Modality AI, David F. Fox and David S. And it's a pretty interesting company. While we are waiting for them to get started.
I'm actually on, I suppose. Can you see my screen?
Yeah, we can see your screen. And I think you won't be disappointed. It's an amazing speaker, and it's going to be very interesting what they're trying to do. So sit back and get ready for this. All right.
Thanks, Venki. It was good event yesterday. Really enjoyed it. Good preview of the exciting presentations of today. So we are Modality AI. We are headquartered in San Francisco, 2.5 years old company. We are focusing on the assessment of neurological and psychiatric conditions through the power of multimodal artificial intelligence. We have heard another speaker today about conversational AI. It's a little bit related, but you will see very, very different also, because we're not looking too much into what people are saying, but more how they're saying things and how they're looking while they're doing this. So the problem we are addressing is that there is no objective assessment for neurological and psychiatric conditions today. So we are talking about things like Parkinson's, Alzheimer's, depression, schizophrenia, autism, on and on. There's 1 billion people who are suffering from such conditions in the world. And it is very, very cumbersome to diagnose these things, monitor these things, screen them, make determinations for things like treatment response, even develop drugs because there's no objective biomarkers in place. The way it's being done today is that the patients have to come to the clinic every 3 to 6 months. They're subject to an eye and ear exam by neurologists, psychiatrists, speech pathologists, who are filling out survey forms that are representing their subjective judgments of the situation, of the behavioral response in these interviews. And that's really used in order to make determinations as to whether drugs should be changed, whether they're working, for whom, and also whether there should be other therapies, or whether there's actually a situation to be considered. One would wish there was a way to objectively measure these things, do so accurately, do so in an accessible form, do so at scale and repeatedly. And so that's basically what we've been focusing on as Modality. We have built a platform that is the ultimate response to that problem. It's based on the idea that we are engaging the patients in a conversation very similar to the conversation that neurologists and speech pathologists are actually carrying out at the clinic, but an automated virtual neurologist that is actually speaking to the patients. So we are following the same protocols, same task batteries, same questions that are normally asked in the clinic. And we're streaming speech and facial responses into the cloud and extract in real time speech, facial, and other visual and behavioral metrics that have been shown in many years of clinical studies to correlate with the clinical endpoints and be predictive of the progression of the disease, and can ultimately be used for diagnosis, but most importantly for screening, monitoring, and as biomarkers in drug development. So there's two major markets we're looking at. One is drug development, biomarkers and drugs, but then another one, which I want to focus on today, is actually the use in clinics for remote patient monitoring and in-clinic assessments. It's a huge space. I was saying there's 1 billion patients in the world who are suffering from this. So what can be done in order to address this? And when you look at a clinic, when you look at how neurologists and psychiatrists are doing things today, as I mentioned, there is now a way for them to scale themselves, to actually emulate one of the major things they're doing, which is the assessment component. So in the words of Arya Anwar, who is the chief physician of the Peter Cohen Foundation, one of our customers, he is saying, I can see 1 patient at a time, or I can see 1,000 patients at a time with Modality. And that's basically what we're doing here. We are emulating the function of the physician. We are bringing these assessments to every single of their patients, do so on a monthly basis, assessments on a monthly basis, accurately and objectively. And most importantly, we have been talking about reimbursement in past conversations. Most importantly, we have shown that these assessments are reimbursable with pre-existing CPT codes for remote patient monitoring. We have actually shown this with Partner Clinic in Nebraska, for example. So not only time saving, scaling, better standard of care, but also a revenue opportunity for the provider. Now the market is huge. I was talking about millions of people who are suffering from this. In America, it's a $45 billion market opportunity, TAM. In America, when you look at CNS conditions, it is about $3 billion obtainable market, which means it's a revenue opportunity for us if we dominate the market and go to this full blast. Now, where do we stand in terms of traction? We have started really 2.5 years ago when we started the company, working with the most prestigious research institutions in America to really build the foundations, to build not only the protocols and the measures and work with the key opinion leaders in the fields of the different disease areas we are covering, but also to verify, clinically validate this technology, work with patients, as many as possible patients, run clinical studies. We are IRB approved 9 times across the nation. We are working with the likes as UCSF, Weill Center of Neurosciences and Autism, on ALS at UT Southwestern, at Mass General. We are live at Purdue with Parkinson's disease, at NYU with schizophrenia patients at the Manhattan Psychiatric Center, and on and on and on. So we have a significant pipeline put together, which you can see here: ALS, autism, Parkinson's, depression, schizophrenia, laryngectomy, stroke, Huntington, and the list goes on with things we are doing. IRB approved partner institutions, recruited trials live and completed, and publications of clinical efficacy in multiple of these disease areas already completed and published. And most importantly, we're very proud of being used by as many as possible patients. You see here over the last 7 months, we have been growing 40% month over month, scaling in 7 months by factor 10 actually, by being used by participants and patients. That's us. We are actually not clinicians. We are machine learning, artificial intelligence experts. I've been in the field for about 20 years, 12 years in leadership capacity, own companies, R&D divisions of larger industrial organizations. I was professor of computer science, where I published over 150 papers and articles in the space of machine learning, artificial intelligence, computer vision, signal processing, speech processing, all these topics that are so important for this technology to work, and numerous patents as well. And we know how to grade and scale systems to huge numbers. For example, with one of my companies in New York, we scaled to over 1 billion such transactions over the phone. My co-founder is also AI expert, ALS and Alzheimer's identification expert, and has had with one of his companies, where he was one of the first employees, a $250 million exit. And speaking of exits, our Chief Business Officer, David Fox, who is on here today as well, he has numerous exits in Australia, in the Silicon Valley, and is investor in over 100 companies himself. And we have Chief Science Officer, Vikram Ramananan, who is our leading expert in the field of speech motor control and is also professor at the UCSF, adjunct professor. And maybe last thing, we have a rockstar advisory board of pharmaceutical and clinical people, such as, for example, Jordan Green, who's the provost of research at MGH. He is the key opinion leader when it comes to neurodegeneration and stroke and their effect on speech changes and visual changes and facial changes specifically. We've been working with him and his team from the very beginning of our company to basically incorporate the clinical findings in the field into our scalable products. Last thing, before I would love to answer your questions, we are raising money. We have actually closed a 500K round in December, are now raising $1.5 million. 315K are in the bank of this round by now. And our milestone we want to achieve is 5,000 patients by the end of this year. And I'll leave it at this and would love to answer your questions.
Thank you, David. Appreciate your time. I think it was a very fast run through, but there may be some specific topics judges and audience may be interested. Last time we talked about it, you talked about Parkinson's or autism or something. And what is your now, when we talked last time, you were talking about some verticals or very specific neurologies. You're working with neurologists. Can you talk a little bit about, and because there may be some neurologists who may be interested to follow up with you.
And yes, going back to the past, so the most experience, and you see this also in a number of publications and where we stand here, most experience we have in neurodegeneration, ALS specifically. We're working with quite a number of different institutions and clinics and foundations on ALS. Parkinson's is the next big thing for us. We would love to work with Parkinson's clinics. If you have any interest in testing this out with us, that would be fantastic. Please get in touch with Modality, and we have very affordable price points for early adopters.
So are you targeting just the neurologist, or are you targeting from the family practice, internal medicine, all the way to the neurologist?
Currently, we are working primarily with neurologists. At some point, it is of an interest and importance to us to also expand it to family practitioners and general practitioners as well, who can use our platform for differential diagnosis as well. But we're a little bit too early for this. Right now, we have been focusing on specific patient cohorts in these disease areas, and we're working with specialists.
So there's another question here from Pramila here. Do you replace standardized tests, or do you get tests validated as well? So we are doing your test as well as a standard test. How does it, what's your current process?
So what we do is we try to be as close as possible to the standard tests, such that the physicians get and have trust in our assessment, such as, for example, let me give you an example of what we do. In neurodegeneration, there's a so-called diagnosis task, for example. The patients are asked to say, for example, pataka, 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 until you run out of breath. And so this is something which a speech pathologist or neurologist would do with the patients. and try to identify, for example, things like how fast they speak, how fast they run out of breath, how many syllables and words they can speak, things like that. We are doing the very same tasks in our platform as well, and many others, and are actually objectively measuring these metrics and produce them at the end in a dashboard to the physician, so they don't have to do this. They can trust in our assessments, and that's the way we approach this. We add a few things, but we also emulate many things that are normally being used in their assessments.
Thank you so much. I think this is a very amenable for the telehealth too. So that's one of the interests for us to also to continue our conversation with you. And
absolutely.
Thank you so much for your time, and please stay and chat.
It's a pleasure. Thank you very much for the opportunity to present today and be part of the Charm network and ecosystem.
Thank you so much. Okay, now we are going to switch, and now the next presenter is going to be Dr. Oren. I'm going to pull up his biography here.
Hey, Venki.
Hey, Dr. Oren, how are you?
Good. How are you?
Yeah, I was going to read your bio, but I think there is no introduction required. I'll just tell everyone he's one of the smartest person you're going to meet. That's an easy one. And he is not only an MD and an MBA, and he's an anesthesiologist and a venture capitalist. So he knows the whole thing from starting from being a doctor all the way to a venture capital and how to raise money and how to walk you through the whole process. So sit back and enjoy his presentation, because you're going to have a lot of questions from our team and our attendees.
Oh, fantastic. I hope so. I'm going to start by first saying thank you for having me. Venki, this is a great program. You guys have done a terrific job, and we're really happy to support this. So thank you for allowing me to be here. I've tried to do something a little different than my normal talk. The topic of my talk is going to be called Getting Funded, because when I spoke with you guys, you said our audience members were primarily startup entrepreneurs. So I wanted to give you something that will hopefully be helpful. So before we get started, I wanted to ask you all to go to the polls. I wrote 2 poll questions, and we're going to refer back to them if we get enough responses. One of them is, are you more likely to? That's what it starts with. I'm looking at the polls. And one of them is, what is the biggest challenge you've had when trying to get VC funding for your startup? That's a short answer. The other one is a multiple choice. It'll take you 2 seconds to fill out while I bring my screen up. So let's go to share screen and go to present. Pardon me. Okay. Okay, so if you guys would fill out that poll, I would be super grateful. And we'll come to those answers in just a couple of moments. In the meantime, I'll get started. So thank you, Venki, for that introduction. My name is Oren Lonicharis. I'm an anesthesiologist and a venture capitalist. I'm actually retired from clinical practice now, but practiced for over 25 years. And I'm very excited to be here. So as I said, today I'll be giving a talk about getting funded. And it's from the venture capitalist perspective, me. It's only my perspective, although I've done some research and some reading. So, certainly I'm sure other people do things differently, but I thought it'd be really great to get some tips from our side of the table. So the subtitle is How to Make VC Friends and Influence VC People. Let's see. Okay, so a brief introduction to me. So I'm the managing partner of the Global Health Impact Fund. We're about to raise our second fund. We are in the process of closing our first fund. After this talk, if you have interest in learning more about our funds, you could be an advisor or an investor. The funds are created to bring doctors and other healthcare providers into the innovation matrix. Please go ahead and reach out to me. My email address is there. It's Oren ORRIN at globalhealthimpactfund.com. Also, we have a sister network called the Global Health Impact Network, which is a collaborative, educational, and innovative network. It's really great. And Gary Goldman, Dr. Gary Goldman, my partner on the fund, is also running that network. And we would love to have you all involved there. The more people we have involved, the better of a network it becomes. So what is the Global Health Impact Fund? Well, we are doctors, entrepreneurs, operators, and investors. We invest in promising healthcare startups. And our goal is to be brilliant and ambitious support brilliant and ambitious founders willing to challenge the status quo and push medicine forward. So really what we're trying to do is create impact in medicine. We know that capital is required. We all get that. Everybody is talking about that today. We're trying to provide that along with the strategic benefit of a large network of doctors. One more thing on me, and then we'll move on. So why do I love being a doctor and a venture capitalist? It's an interesting story. When I started, I learned about venture capital when I was getting my MBA at Columbia University in New York. This was when I was in my attendingship at St. Vincent's Hospital. And I was fascinated by it. It was like a puzzle. And if you put all the right pieces together, you can get something very special. But it wasn't something, it was more like a project or a challenge. You know, can you find good things? Can you do important things? But it didn't make me passionate. It made me curious. And then one of my colleagues, who was a good friend of mine, told me that his daughter was sick. She had glioblastoma. And many of you know, if you're familiar with the disease, it's a terrible, terrible disease. It has a worse prognosis in adults, about a 15-month survivability, but it's still very, very bad in children and can be also lethal. And I wanted to do something about it. And I realized that because of my access to venture capital, because of my access to startups like the startups we're hearing from today, that I could go and find startups who are working in the space and maybe help them find funding and support them to bring their innovations to the market. Because there really aren't innovations in that space that are saving lives today, not enough at least. And I did just that. And I was able to invest in a company. It's called Cortana. You could look it up on the internet. And they're doing research. They're still doing research. And their biggest challenge has been getting capital because it's expensive to bring a drug to market. But that was the moment in time at which I realized we can make a difference. And we can make a difference at scale. If we bring a drug like a glioblastoma drug to market, I mean, this helps so many people and it's across the world. And that's, to me, why we do this. Yeah, we'll make money and that's great, and we'll help people and that's great, but the magnitude of impact on medicine and the care of people is why I do it. So that's my personal story. And I tell you my personal story, I'm just going to move this over here because it's part of getting funded. So the journey of getting funded is really the journey of 1,000 no's. And what I want to try to do today is help you reduce the number of no's, but you'll still get a lot because we look as venture capitalists, 1,000 companies for every 1 or 2 we invest in. So we're going to talk about storytelling. We're going to talk about tips for your slide deck. We're going to talk about being prepared. And then lastly, we're going to talk about something a little bit tangential, but it's organizational psychology. And I hope that you'll find it interesting. And I hope maybe you'll see some of these things in your own experience and figure out how you can optimize your work. So, whoops, too far. So when you're telling your story of your company, you could be very dry. We've created a device or a drug or a platform that can do this, and people are going to use it and it's going to be great. But that's dry and people can't connect with that. And you want to make a connection. You have a very short period of time. So think about creating a narrative. You're not building a bridge, you're bringing people from 2 sides of the banks together. That's what we try to do. So use testimonials, use case studies, create narratives. And this is a really powerful way to tell a story. So think about storytelling. So we all have to have a problem statement in our slide deck. And one thing I see very frequently is people go on and on, slide after slide, about diabetes and how many people and how terrible it is and what happens. And I think that that's not what you're doing. It's important to show that what you do has relevance and has has, expanse, but it's not important to tell every little detail about that thing, because it's more important to say what you're doing. So be clear, but assume that people reading this already have a basis of a knowledge base of the problem. And so really get to your solution and state the problem as an equation that you can solve. And I think that's very effective, because you're only going to have so much time and so much attention. So you don't want to waste it on things that don't directly speak to you. And so Michael Porter is a professor out of Harvard. I imagine he's retired by now because he's been around forever, but maybe not. And he wrote something called The Competitive Advantage. And this was a really influential work in business. And he basically said there are only 3 ways to compete in the marketplace. And you can either be the best solution, the cheapest solution, or operate in a niche that nobody else is involved in. And that's it. And it's really a very interesting sort of way to look at the world. And so you want to answer that question. Are you the best? And if you are, make a defendable statement of superiority. Do you have good IP protection? Do you have good market protection? Like, tell us as quickly as you can, as briefly as you can, how you do that. Very important. Another thing to think about is, how do you optimize your deck? And so it's really common. I get decks and they're really very full and very busy. And it's hard to read all of that. It's hard to remember that. And so this is your first impression. And this is the thing that's going to let me move on and decide whether I want to engage anymore. So first, let's talk about the rule of 3 things. And I don't know if it's really a rule, but I think that as a rule is that people remember 3 things about a talk, 3 things about a deck, 3 things. So what 3 things are the most important thing that you want your deck reader to remember? And repeat them. Repetition is a powerful tool in crafting narratives. So think about writing, and the writing is really small and the charts are hard to read. Well, then they're not going to read them, because people will only devote a certain amount of time. So limit the verbiage, use pictures, use charts, have a clean deck. And, when people want to look at studies, when people want to look at more detail, they'll either ask for that, or you can put them in an addendum at the end of your deck. But at least this way you get them through the whole story without a distraction. And then the other thing that's really important is that the goal of, when you send your slide deck out, in my opinion, the goal of sending that slide deck out is only to get a call and generate interest. You're not going to get an investment based on your slide deck. So can I get a phone call? Am I going to whet your appetite? So if you think about it like that, you don't have to put everything in your deck. All you want to do is get that phone call, and then you can have a more complex discussion, and then maybe you'll get a meeting, and so you build a relationship. And quite frankly, that relationship building itself is valuable because you get to know people and they get to know you. So just think about that. Really, decks should be clean. Now, it is important to step back and recognize there are 2 decks that you should have. One deck is a deck you present, and that should be really lean because you're going to be talking over it. You don't want to read your deck. Although I'm reading mine a little bit, you want to be able to have a conversation, and the deck is a prompt. Whereas when you're sending it and you're not presenting the deck, then that deck has to be a little bit more, have more expository in it so that it can be self-explanatory. So it's good to have 2 different ones. So another thing I see a lot is projections that are just wild. So I just wanted to spend a moment talking about projections and what you should think about when you put projections down. If, for instance, you're in the orthopedic screw market and your screw is superior than all other screws, and you could, and your first target market is trauma surgery, that's great. If you tell me that the total addressable market for trauma surgery is X, and X includes all surgeries, all equipment, all doctor's fees, et cetera, that's not a number that means anything to me. What I want to know is how many screws are used in trauma and how much those screws cost, right? So it's a much more well-defined market. And then you can say, well, and we can expect to get 3% of that market in 2 years, and that'll be worth X. And that's a projection that I can hang my hat on and make decisions based on. And I might make have different opinions. Maybe I think you can do better or worse, but at least that's a good starting place. when it becomes a catch-all bucket for anything related to trauma, in this particular case, it's just not a material number. So be careful about that. I think, you can use that number to help you, or you can just, again, confuse things and then creates a credibility problem. So assumptions that are, we all know assumptions are based on best case scenarios, and we all everybody laughs at projections, right? Because, the joke in venture is everybody's making $100 million in 3 years. But it's the assumptions that matter. And I can play with the assumptions. I can adjust the equations in a way that allows me to get a sense of what's happening. So it's really your assumptions that are critical more than the absolute numbers that you're defining. And if you have weird assumptions and weird projections, it just undermines your credibility and makes it seem as though you don't understand your market. So again, my cautionary tale here is think about those things and, try to put together a presentation that just makes sense, right? That makes you look like you're the sort of master of your domain. And then another thing to think about is to know your venture capitalist. Chance favors only the prepared mind, says Louis Pasteur. Kind of important guy. So what do I mean by that? Well, every venture capital firm is a little bit different. And if you know a little bit about them before you have your meeting or before you email them, well, that could save you a lot of time, or it might lubricate the conversations better. So some of the things you might want to know is, what do they invest in? Are they healthcare investors? Are they passive investors? What is their check size? What vertical are they in? What's their portfolio look like? What stage of company do they invest in? All of that stuff is relevant. What's their investment thesis? What's their investment history? Do they have good contacts or domain experience? What value can they create for you as a company? Some venture capitalists will write a check and they're going to be hands off. They're very passive investors. Others are very active, like our fund. We try to take board seats on every company that we can. We want to be involved. We think that our network of physicians is very valuable to these companies. And our companies are very appreciative of that. But not everybody wants that, in which case we may not be the best investor for you. So it's important you sort of know who you're dealing with if you can. And if you can't, those are good questions to ask, but it definitely prepares you for your meeting well. Okay, and then I think this is the last one in the thinking about the deck, but avoid unforced errors. The fault, dear Brutus, is not in the stars, but in ourselves. What do I mean by that? I mean, don't make mistakes that you don't need to make. Be on time, right? It seems small. Be prepared, be polite, right? These seem like common things our moms and dads would tell us when we're growing up. The problem with being a VC is that, you read a deck, you look at some data, you make a choice, right? And obviously there's more that goes into it, but it's not, it's like you're getting married to somebody without really knowing them. And so you look for things that are proxies for real deep knowledge. And, things like that person is always late and the person never said thank you for the time that I spent, or was really defensive when I gave them the feedback. Those aren't necessarily meaningful in the big picture, but it's the best data we have to make decisions. And you want to make sure that you've done the best job you can, because if not, they all look like red flags. And it's not unusual to look backwards at investments you've made and think about those red flags and think, what, I knew better. So don't create those errors, think about it and just put your best foot forward. These are silly things and it has nothing to do with your competence as a scientist and business person, but in many ways it's sometimes more important. So that's kind of all of the slide deck and storytelling. Just to summarize all of that, it's about telling a good story, telling it in a way that is tight, using repetition to your advantage, and making sure there's credibility in the data that you put out there. There's always room for more. So you want to keep this as tight as possible. The follow-up is where you get deeper. The follow-up is where you get more in-depth and more complicated. I guess the last point I'll make is the question about NDAs. I get this a lot. A lot of startups want us to sign NDAs, non-disclosure agreements. And I'll say that some people do and some people don't, but I would say that the balance of venture capitalists that I've spoken to about this do not sign NDAs because it creates a liability for us. My recommendation is if there's something that's super confidential, that if it gets out there will cause you great duress, don't share that part. You know, in this storytelling that we talked about today, you don't really have to get in depth and like show people your patents or which are published anyway, but you don't have to be super specific. What you want to do is create interest. And the truth is, I don't mind signing an NDA at some point. I just don't want to sign them for everybody because it's a liability that I can't even control. So, you know, at some point in time, if a company says, okay, I can only show you so much, but if you're genuinely interested, we'll have to go down the NDA route. At that point, I'm probably okay with that. So just, again, a little bit of advice. So jumping into the next part of this talk, I wanted to talk about organizational psychology. I guess we'll take questions at the end. I don't see the chat box or anything, so we'll do that at the end. And again, I hope everybody's had a chance to fill out those 2 polls. They're super quick. So it's basically the application of psychological theories to the organization and individuals in the workplace. So how do we make the workplace more efficient, more effective? And honestly, I have to do a hat tip to Adam Grant, who's a Harvard grad and a Wharton professor and a TED talker and a New York Times writer and an author and an award winner. I mean, he's really interesting. I've listened to podcasts of his, and I really recommend it. I'm reading Think Again right now, and I get a lot of this material from there. So big recommendations, and thanks to him for his work. So why are we talking about this? Because at the end of the day, venture capitalists invest in people. And so the joke in venture capital is that what are the top 4 things we invest in when we look at a company? Well, it's the team, the team, the team. Oh yeah, and the idea. So it's really the people are critical. And of course that makes sense, but that is not apocryphal, it's real. So what do we want to know? Well, we want to know about their skills, their expertise, their experience, their values, and their passion, their conviction. Are they going to stick with this? Because you all know that this is a hard and lonely job, and it does not really reward you for a long time, if ever. So let's talk a little bit about people. So the first thing I want to talk about is, let me get that little dot out of the way. The first thing I want to talk about is to succeed in business, I want you to think like a scientist. Now, it's a funny thing for me to say to this group because there's so many physicians and clinicians here, but it's not unusual for even scientists who become business people to forget to think like scientists. And a classic example of that is the leader of BlackBerry. And I hope most of you are old enough to remember BlackBerry, but maybe not. But the leader of BlackBerry basically, created I think a $17 billion corporation with the BlackBerry, and it was, a device that you could send emails and you had a keyboard, and the iPhone came around, and he was very resistant to, having a web browser and creating, getting rid of the keyboard. Like, he was just very fixated on it. Well, BlackBerry is really not worth hardly anything anymore compared to its peak value, and it lost its market dominance because he stopped thinking like a scientist. This was a guy who, when he was a child, was inventing things, and his whole life he was a creator. But he became a business person and stopped thinking like that. So how does a scientist think? Well, I'm an anesthesiologist, and so I always think about it as an anesthesiologist when I'm in the operating room and I put a patient to sleep and their blood pressure drops. So what do? Well, the first thing we do is we collect data and we observe. So what is the blood pressure now? What's the heart rate? What does the patient look like? How's their oxygen saturation? Is everything functioning well with respect to ventilation and so forth? Then I treat. I make a diagnose. Well, they have, vasodilation due to an induction of an anesthetic. Their blood pressure is low because they vasodilated. So let me go ahead and give them a medication to vasoconstrict them. And I pull out my phenylephrine, I give them a little dose of phenylephrine and I see how they do. So I observe, I diagnose, I treat, and then I can, I start that cycle again. I get another blood pressure. I look at what's happening with respect to their urine output. Is their blood pressure come out? What about their heart rate? And I go through this cycle, and it's a constant cycle throughout the operating room of observe, diagnose, treat, observe, diagnose, treat. And, that's the way we think as scientists. So what does this mean? It means that I'm always challenging my thesis in the operating room because, hey, maybe it's not that they're vasodilated. Maybe it's that their compliance in their heart is poor, or they're bradycardic, or maybe it's something entirely different that's one of the more zebra-like phenomenon that could happen in the operating room. It's hard to know. So what you want to do is either internally or even better, externally with people around you, is engage in healthy debate about the facts. But if you're thinking about it like a scientist, the goal is to get to the truth, not to defend your personal fiefdom, right? So you're not getting personal. You're not, your feelings aren't getting hurt. And why do we want to do that? We want to do that because we're biased. We're all inherently biased. We have ideas. And there are two main biases that come into play here. One is a confirmation bias. And that's that we see what we expect to see. And the other one is desirability bias, which is we see what we want to see. And so it's super important that we think like scientists and we put the biases to the side and we put the defensiveness to the side, and we'll be better operators. We'll be better business people. So there's a great experiment that was done in Italy, in Milan, and they were doing an entrepreneurial course for people in retail and fashion. And they said, we want you to come here and we want you to build a minimum viable product that you can sell in retail. And they had two groups, a control group in which they did the normal, sort of accelerator training. And then the second group in which they did the same exact training, but they taught them how to think like scientists. And so what does that mean? They say you start with a theory, which is your strategy. You develop a hypothesis, which means you talk to your customers and you see what they want and you challenge, you test your hypothesis. And then ultimately you create a minimum viable product. And that's considered your experiment, which means that you don't know what to expect and you're going to see and collect your data. So that's what they did. Otherwise, these two groups had the same experience. They came back a year later and followed up with the two groups. The group in the control group averaged about $300 in revenue, which was good, but not terrific. The other group averaged $12,000 in revenue. I mean, this is a marked difference. And the only thing that was different in the two groups was one thought like scientists, one did not. So I would encourage you to think like scientists. And fortunately, most of us are scientists, so it's not that hard. It's not that hard. So just don't lose that when you get into business. So the next principle I want to talk about is the confidence to competence ratio, and what that means.
Dr. Oren, sorry to interrupt. I
yes,
think you are try to wrap up. I think it's
try to wrap up.
Sorry about
that. What time I thought I had an hour. Okay, I'll be fast.
So we had 20 minutes, sorry.
Okay, my apologies. So this is just basically, many people think they know a lot more than they do. And you want to work with folks who maybe are more humble. And that's the poll that I put out there. If you think you're the smartest person in the room and you never make mistakes, that's really not somebody a venture capitalist wants to work with. The people who are imposters, they're going to work hard to prove they belong or feel that they're imposters. They're going to seek out teachers and they're going to take in new information. So this is something called the Dunning-Kruger Effect. And basically it says that the know-nothings think they know everything. And, this is Mount Stupid. You don't want to live on Mount Stupid. And so the more you know, the less you think you know. And we've studied that, and I could tell some folks about the studies if they want, but we don't have time for that, so I won't. But basically, you want to work with people who are humble and have humility and are willing to listen to feedback and consider that an intellectual challenge. And that's really important. We give feedback as venture capitalists, and we want startup people to appreciate that because we don't have to give feedback. We could just walk away. So we consider it, a gift, even if we're not going to invest because we've seen things and we might be wrong. It's not that we have all the answers, But if you don't even want to hear it, then that's hard to work with people like that. Very briefly, the benefits of the doubt: it can make us work harder, it can motivate us to work smarter, and it can make us better learners. And that's really why we want folks to operate with humble humility and confidence. And then does it lead to funding? Well, healthy organizations are more functional, more efficient, and more fun to work with. So VCs want to fund success because success creates impact, and also success leads to return on investment, which is ultimately how we're judged. So this funding is a proxy for what we think will be successful. So optimize your funding, your organizational structure. I want to wish everybody good luck. I'm sorry I had to rush at the end, but I'm happy to have conversations about this if somebody's interested. And here's some contact information for me if you have any questions. Thank you, and enjoy the rest of the show. And do we have time for Q&A?
We can open up for a couple of questions. So
okay.
I have a couple of questions, but
okay.
Open up for judges and panelists. If you have questions, please ask now. Okay.
In the chat, I saw some chat box.
Yeah, no, I have a couple of questions, but because we are running out of time, we can take it to the chat. But basically, we want to ask you, do you have a checklist for filtering those business ideas or business deals comes to you? And then what is your sweet spot? I think those are the two things we can maybe chat offline. Yeah.
Okay. Yeah, whatever you want.
Yeah, if you have time, just talk about those two things. If you have a checklist and a sweet spot.
A checklist for due diligence. We have a very complex due diligence process. Basically, what we do in a nutshell is that we look at first the clinical application and integration and the science underlying the work that the startups are doing. If they pass through that filter, we look at the components of the business, total addressable market, the user experience, the payer codes, and so forth. If they pass through that filter, then we look at the financial risks. How much money do they need to raise? How many other rounds do they need to raise? What are the valuations and things like that? And I think that's the way I approach these things. But of course, it's a much more comprehensive approach. So what we do is we try and filter, right? Because I want as many decks as I can get, but then I only want to spend a lot of time on the few that I'm very serious about, the few companies. In terms of our sweet spot, my fund invests between Series Seed and Series B. We write typically $1 million checks. We're raising a new fund now. So hopefully we'll have some capital in the immediate future to invest in more companies. And we want to invest in companies, obviously in healthcare, that we feel that our strategic network can make a difference with, and that we can have a real impact on the way healthcare is provided. The last thing I'll say is that venture companies need to demonstrate, given the risks that they create, a good 20 to 30x return on investment. And if they can't, they may not really be good companies for venture-backed investing.
Thank you so much for your time. Appreciate it. And we'll chat again. Thank you.
Thanks, everybody. Take care.
Thank you. I think we are a little bit behind schedule, but it was a very fantastic presentation. We could continue for more than an hour now. So let's start neuro audit, and Dan is getting ready to get started here. Dan, thanks for your patience. Let's get this going.
Yeah, actually, it was interesting. I'm Dan from Israel, and in Israel now it's after midnight, and I think I'm the last one that haven't left the building. So let's start. I'm Dan from NeuroAudit in Israel, and in NeuroAudit, we developing intelligence patch driving instant cognitive boost, actually. Few words about NeuroAudit. We based in 2016, and we developed very innovative technology, psychoacoustic neuromodulation technology, actually for brain disease, brain disorders, but we developed the first daily neuro patch that driving instant cognitive boost, and the innovative, unique things that we speak about is actually for healthy people. We speak about healthy people. World Health Organization find in 2019 a really big challenge that our population, world population, use more sugar, caffeine, energy drinks, and even drugs like Ritalin, vitamin, etc., etc. We even found that in the US, more and more college students use energy drinks, drugs, alcohol, and we found that more than 50% of the students use actually drugs for ADHD. And for us, it was kind of amazing. That's why in Neuroaudit, we developed the daily patch actually. And when we speak about daily patch, we are not speaking about a wearable device, because in Neuroaudit, we believe that the daily patch, you can use it, and in the end of the day, you can throw it. And the day after, you can use another one. So about the daily patch, it improves instant cognitive boost during the stimulate, and it's based the psychoacoustic technology, and improve focus for healthy people. That's why we are really believe in Israel and also in Neuroaudit that we need to invest in the future that called neurotech, actually. We found that our technology gave more than 20% of cognitive boost. And I'm not sure if you all know, when we speak about cognition, to speak about 20%, it's something really big for us to understand that we can do it. So we have big challenge, we have huge market, and we have very innovative technology to speak about. And if we want to speak about investment benefits, in a minute, we are going to speak about that. Neuroaudit based so many test cases all over those years, few of them around TDCS. This is electrical stimulation to the brain, later on around ADHD to understand what is the cognitive and the focus and the attention signal. And of course, what about sonic signal that effect on our brain, later on about EMG, and at the end, of course, ultrasound stimulate to the brain. Our last test case was in Japan, actually, sorry. Our last test case was in Japan before the Corona situation started in December 2019, and we found some amazing results. More than 70% was correlated with less brain activity, much higher cognitive performance, less brain activity. At the first discussion, it was kind of gap dissonance for us to understand what about less brain activity, because we took the left brain activity down and actually got much higher cognitive performance. So at the beginning, it was kind of gap dissonance for us to understand those, but today, we understand that during our stimulate, we take the left brain activity, relax, and get much higher cognitive performance. When we speak about our base technology, we support in many clinical experiments that we found all over the world, also in Japan, because in Japan, to speak about ultrasonic neurostimulation to the brain, it's very familiar. And today we understand that ultrasonic stimulation to the brain via the blood, we call it blood conduction. We understand that there isn't meaning like that that's called blood conduction. We call it blood conduction. And the unique things that we are using our patch on the carotid, because the biggest challenge that we have around neurotech, that we have the scalp. This is bone actually. So we cannot understand what's going on fixed inside. So that's why we are using blood conduction. At the end, we send our technology and get familiar with the market and some papers about that. Few words about global activity, because I start up with Japan. In Japan, there is so many problems to speak about with Alzheimer's disease, and a few more problem challenges like the hikokumeri disease, people that stay at home without social relationship. So we gave many lectures in Japan around neurotech and startups from Israel, actually. And we had the test case with Astem company in Japan, and we had done the Keiga Plus program in Kiana Research Complex in Japan. So basically, you can understand that our first market, of course, this is in the US, and the second one in Japan. Our the base founder team is me, of course, and Dr. Lionel Kriya for many years around Alzheimer's disease, with few patents around PET-CT. Alon Sinai, neurophysiologist from Rambam Hospital in Israel, work with focus ultrasound technology, and Boaz Sadeh also work with so many brain technologies like TMS, this is electromagnetic stimulation to the brain, and TDCS, this is electrical stimulation to the brain. And today we are speaking about the new innovation technology that's called ultrasound stimulate to the brain. Our product roadmap, actually, we completed the test case POCs and our prototype development all over those years after all the test cases, and we send our provisional for patent. We have a very unique timeline because we jump to the market. We are ready to the market, actually, to jump with wellness version, wellness product, but we watch our clinical side. As I said before, we start with in the US market with the college students, but later on we are speaking about the Japanese market and around Alzheimer's disease, deep science behind. When we speak about investment roadmap, we are also watching the investment side. We speak about short ROI, low risk for the investment, and huge market to use our technology. Why? Because when we speak about the product benefits, we speak about low cost product, low manufacturing cost, and at the end, we speak about still deep technology. Ultrasound stimulate to the brain, we speak about deep technology. Our first milestone speak about 9 months. This is the first seed fundraising for us. And I will stop here. I was Dan Anzio from Neuro Audit. Any question?
Thank you, Dan, for your time. Appreciate it. Can you hear us okay?
Yeah, of course.
Okay. Yeah, I think it was well. I think you came on time, and I think it's a very clear presentation. So there are some questions on the chat. Let me read it out for you if you can hear us. How does the clinical trials working out for neurodevelopmental disorders and intellectual disabilities and autism, because your TMS versus your new technology?
Yeah, TMS, actually, it's not new technology. There is so many companies around TMS technology, electromagnetic stimulus to the brain. And we can find also this is TDCS. This is a familiar technology that work in the US, many companies that work with electrical stimulation. And when we speak about those technology, basically we speak, first of all, on our scalp. And as I just said, we have a big challenge because we have the scalp, it's bone actually. And secondly, we speak about regional technology stimulate. And if we speak about ultrasound stimulate to the brain on the carotid, actually, we speak about via the blood. As I just said, we call it blood conduction. There is no meaning that called blood conduction. We call it blood conduction, actually. And this is for specific region on the brain.
Thank you so much. And please stay on the chat line, and maybe you can answer a few questions.
Yeah,
and
I will be glad.
Thank you very much for your time. Appreciate it.
Thank you.
Thank you. Okay, I think the next speaker is Ian Davis, Forge Prosthetics. Ian, are you ready? Hello, Ian, can you hear us?
Now,
Okay.
can you hear me now?
Yep. Thanks, Ian. Thanks for your time. Appreciate it. Let's get this going.
Thank you. Okay. Where are you now? Okay, so which screen can you see?
We can see your screen.
Okay, so you can see my healthcare screen? Okay.
Yeah.
Hello, I'm Ian Davis, and I started Forge Prosthetic Devices in 2019 after spending a year living inpatient at UAMS in Little Rock, Arkansas, undergoing 4 cycles of heavy chemotherapy and an autologous stem cell transplant to treat stage 3 multiple myeloma. What I noticed since joining the Missing Parts Club in early 2019 is that the products that are available, that are offered for solutions for partial hand amputees, currently are slow, cumbersome, and difficult to use in general, and don't offer a very enjoyable solution for day-to-day interactions with physical objects. Now, just to get a sense of what it's like, hold out your hand and open and close it as I play this short video, and see what it's what it's like to have your hand move at the speed as you go throughout your day-to-day. It'd be incredibly frustrating. Now, about 6 months after my stem cell transplant, I shattered the proximal bones of my dominant hand as a result of super low bone density that often comes along with multiple myeloma. Unfortunately, after the surgery to repair the fractures, a blood infection set in, and the only solution was to amputate the fingers of my dominant hand. Initially, my insurance company denied my request for the prosthetic device. That led me to take measures into my own hand and begin designing a device that would help me in my day-to-day needs, only with newly imposed constraints. Initially, I wanted to follow the lead of industry and build a myoelectric controlled device that was motor-driven hand. But after completing that device and using it for a short period of time, I decided that the user experience would be better if the device was entirely mechanical rather than actuated by myoelectronics. What I discovered from that process was that mechanical hand offered superior experience in comparison to the electric hand, because not only did it never run out of batteries, but since it was powered by the action of the wrist, it also offered the user a sense of prior perception not available with a myo hand. Initially, my designs were 3D printed on a resin printer, but after using that series of devices in the real world, it became apparent that the next issue needed to tackle was that of durability. Resin printed fingers were awesome because you could just print go and 18 hours later have a set of fingers ready to finish and assemble. The issue with it is, in the end, they're just made of plastic, and during normal use frequently develop fractures at the pivot points of the fingers, necessitating frequent replacements. This is where I began fabricating the components of fingers from aluminum and brass. Shortly after this advent, I added the display function to the hand. Initially, I thought that it might be a bit of a zuzu, but during the past year that I've been using the hand, I found that it was very reliable and useful day to day. So much so that I've incorporated the display into my latest hand. Speaking of advents to the new build, that brings me to this. My current prototype, this version takes everything that I have learned from my previous devices and also what I've seen from the commercial prosthetics hand market and combined them into one device. This version is a hybrid device. The fingers are mechanically driven. Individual addressability of the fingers is achieved through a gesture-based HMI. In practice, say the user wanted to lock the ring and pinky finger. What they do is they touch the capacitive touch button for the menu, and that puts you into grip mode. They'd move diagonally up to highlight the index or the ring and pinky. They'd close their hand, and then when they open it back up, only the non-locked fingers would stay closed. To open all the hand up, you'd go into the grip mode again, hit select again, and the fingers would open up. Next, another feature of the hand is that it incorporated 2 high-intensity LED strips onto the palm of the socket. Totally a Zuzu, but I think it would definitely be useful in the day-to-day. Last year, I started documenting the process that I've been going through, making my hand on both Instagram and YouTube. As a result of that, I've been contacted on average by 2 to 3 people a day requesting that I making inquiry about me supplying them with advice because X tragic thing has happened to themselves or one of their loved ones. Now, of course, the amount of time that's required to design a prototype, and such a bespoke device, I'm not able to meet that need. So instead, what I've been doing is putting together a series of YouTube videos showing a person how they could build themselves a device if they were so inclined. With these videos, I've been able to help a lot of people from just where they live. For the people that decide to take on the challenge of building themselves a hand and run into issues, I help them through direct messaging on my Instagram page. And for the individuals that have a reasonable expectation that one of my devices will bring to their lives, but aren't inclined to build their own, what I've done in the past is have them follow along on my DIY socket series of videos on YouTube, build themselves a fitted socket with a silicone liner from readily available materials. I then have them wear the socket daily for a couple of weeks and make sure it fits them very well as their hand naturally shrinks and swells throughout the day. During that time, I fabricate the mechanical portion of the device that we agreed that would be best for their situation. Once everyone is sure that the socket fits well, they send the socket to me with a bunch of reference images and where I assemble the rest of the device and then ship the completed device back to them. For the most part, I'm focused exclusively on the solutions for partial hand amputees because I can relate to their day-to-day circumstances. Hopefully, when my project makes it to the next level, I'm able to get my hand to everyone that is in need and still be able to do it at a reasonable price point. Like I've said all along concerning this project, I need to make money, but I don't need to make medical money. Between what I do on YouTube and also in the private market, I really do feel that this is the best use of my bonus time that I'm currently living in. Being able to have an effect on society and lending a hand to those that are in need. Thank you.
Thank you, Ian. Appreciate your presentation. It was so. Did you talk about the how much raise your funding you're asking here?
Right now, I'm still building interest through the major like OSERV, eBionic, Arm Dynamics, those people, because they're so embedded into the market, they already have the FDA approval. They already have agreements in place with different O&P to where they're already a standard industry with market.
Excellent. I think this is a very good topic that we need to again revisit in Clubhouse as we talked about on Friday. So thanks again for your time and looking forward to talking to you soon.
Oh, thank you.
Yeah, I think our next speaker is from Upfront Health. Dave, are you ready for your pitch?
Yes, I am. Hold on, let me pull it up.
All right. Thanks, Dave, for your time. Appreciate it. And
actually, the previous slides are still up.
Yeah. Hey, Sesh, can you take care of that? Yeah, it's all yours now, Dave.
hold on, let me just. All
Then we
right.
can see your screen.
Yep, you can see it now? Okay. Sorry about it. Thanks. I'm excited to be here. Thanks for joining the presentation, and thanks to CharmHealth and iValley for putting this together. It's been on most of the presentations today. It's pretty exciting and cool. It's great to be here. Hold on, I have to move something on my screen so I can see the notes. There you go. So just before I get into this, a little bit about me. I've been in health insurance and healthcare for over 25 years. About the first half of those I spent in customer research. So researching consumers, insurance members, patients, employers, brokers, really getting to know what's important to them and how they work with each other and how they don't work with each other. And then I spent this second half of my career until now as an improvement consultant, doing something about what I discovered. So how do we improve the healthcare system? That's my passion. How do we make the product, not the product, how do we make the whole system work together in a way that really works for the patient? So what's the challenge? I'm not going to go into describing all the problems in healthcare. I don't think anyone in the audience would be here if you didn't know that there's improvement needed. I will give you a couple of examples. One just earlier this year where Haven Health closed its doors. So for those of you who don't know, Haven Health was Amazon in partnership with Berkshire Hathaway and JP Morgan Chase, had the most brilliant, or had brilliant minds together to fix the healthcare problem. They couldn't get out of their own way and they closed. So if Amazon, who can deliver a box of Q-tips 2 hours after I ordered it, to my door, but they can't figure out how to improve healthcare, are we all doomed? There's been and there are other players out there like on the screen, Oscar and Uda Health, other innovators that have come in. I wouldn't call them disruptors. They're definitely making some improvements, but the challenge isn't, how do we make incremental improvements and make things better? But, the system's so old, slow, all the things we've heard all day are wrong with healthcare. We need a disruptor, and a disruptor will be there. Who's it going to be and how's it going to happen? So overall, the challenge is very simple. Healthcare just needs to be cheaper, simpler, and more effective. So imagine transforming to a new way to navigate the healthcare system with no paperwork, no bills, no surprises, no worries. Because greatly just simplifying the way you navigate the healthcare system in a way that reduces costs by 40%. So who wouldn't want to reduce costs in healthcare by 40%? Well, let's think for a second of how the healthcare system got to where it is now. Who created the current way healthcare is managed in America? Insurers, hospitals, physicians, all the parties that organize how employers provide insurance to their employees, and the government. Do you think any of them want to make 40% less? No. And then who funds all this? It's really the patient. So the patient pays for this through direct payments, they pay through their taxes, and they pay through their employee benefits, that the whole inflated system. So what happens when you flip that around and design a system that's really focused on the patient, that puts the patient up front and center? Before I get into showing you a little bit of it about the solution, let me just talk about the 3 core components and tenets of upfront health. So this is really kind of the engine of what makes things appear simple to a patient when they navigate the system. First component, I'll start on the left here, is clear upfront costs. So what we're talking about is managing their benefits with 6 clear, basically cost shares to the member. There's only 6 different categories that a patient is going to have to pay for. I'll show you in a second. That'll make more sense. But very clear, no deductibles, all healthcare speak that people have become experts on or not experts on. you do away with. It's just very clear what you're going to pay before you go get any care. Partner that with providers that really are incentivized to make a difference. So basing this on value-based networks, and what that really means is providers who make more money, the healthier you are. Then you're in a true partnership with your providers. And the current system, providers make more money by how much work they do. So how many tests they order, how many treatments they give you, and how much equipment you get, et cetera. And then luckily, since we're in 2021, and not 1980, you can put all this together with computers. So a digital interface to pull this all together, integrate and automate everything from the time you think about getting care to the time it's delivered, and all the bills are reconciled, and your insurance is reconciled as well behind the scenes. But completely seamless, no papers needed. You can really take out all the administrative overhead by effectively linking this together with an integrated digital solution. So just a little preview. So what does it look like? Excuse me. Here's a preview of upfront. So busy slide, so I'm going to walk you through a couple of it, because the 6 care categories I was talking about on the left on a screenshot of the app, basically $25 if you want to see a doctor online. Make an appointment online, $25, simple. Want to see a doctor in person, $75. And that's not just doctors, but if you want to see a specialist, therapy, mental health, $75. Something urgent comes up, you need to go to an urgent care, or you haven't made an appointment, it's more convenient to go to an urgent care, $150. Emergency happens, or you have a baby, or you get a surgery, $500. And if you're in the hospital overnight for whatever, surgery, planned or unplanned visit, $1,000. And then different cost categories for prescriptions. Now, these amounts all are derived, they're actuarially sound to net in a reduction of, basically the reduction of premiums for the insurance folks in the audience. But again, no deductibles here. You can put an out-of-pocket max on here. So if without increase, well, with a very minor increase in the cost, out-of-pocket max of $5,000, meaning say you had 5 hospital visits in a year, the most you're ever going to pay is $5,000. Still nets in a net reduction of costs. So just a very quick, I'm doing a time check, very quick walkthrough of an example. So Jamie's a mother of an 18-month-old. She is awoken at 3 a.m. by her screaming baby, nervous and panics, and wants to see her doctor. Takes out her upfront app, 2 clicks, and she makes an appointment with her pediatrician for early in the morning, or for early in the morning. She could have seen a provider right then online for $25, but she really wanted to have her son checked out. So play this forward, 9:30 is her appointment. She walks into the doctor's office, gets a notice on her phone that she's checked in, sees the doctor. She diagnoses an ear infection, prescribes an antibiotic at the CVS near Jamie's home. On her way out of the office, Jamie gets another notification. Thank you for visiting. Your payment was received. Would you like to give the provider a rating? She drives to the pharmacy. By the time she's there, the prescription's ready to pick up. Goes through the drive-through, picks it up, gets another confirmation that her prescription has been paid for. That's all. She never had to touch her wallet. She never had to sign one piece of paper. She was worrying about taking care of her son, so that's what she was able to do. Later that afternoon, the doctor's office calls back to check in on her son. So here's a mom who all she had to worry about was delivering the care. She didn't have to worry about the administration involved. So why does this work and what makes it simple? So if you remember, I spent over 10 years researching the customer. So what's most important to the customer almost doesn't matter how you ask. There's surveys out there like crazy. The same things keep coming about what's most important to the consumer. Affordable care, they're not saying free care, they know they have to pay for it. They do need help finding a doctor and navigating the system. They want to know their costs up front. So very important that it relieves a lot of anxiety, even if it's an expensive procedure or whatever, that they know how much that's going to cost before they get the treatment, helps them make decisions and helps them plan financially. And ultimately, they want to be healthy. So I'm going to skip over the competitive analysis slide that I have here, but basically of all these key concerns to the patient, the way Upfront is designed kicks butt. It actually meets all the needs for the consumers and patients are looking for in a healthcare management system. So
Hi, Dave, I think we are running out of time, so you need to save some time for questions because there are a lot of questions coming up on the chat. So
okay, great. So luckily we're at the conclusion slide. So I'll just close by saying this really works because of those three areas working together, the technology pulling together. What's most important, it helps the patient navigate the system, helps the providers provide medical assistance, not administrating the plan, and it takes almost all the administration out of the plan by automating everything. So there's some screenshots at the end of the deck you can look up online and click at those, but I'll close out here and answer questions.
Thank you, Dave. So we have a couple of questions. Let's ask our judges to ask you questions. So Dr. Dickerson and Solis, Dr. Solis Saunders, if you guys have questions, go ahead.
Yeah, this is Dr. Dickerson. I'm in pediatrics, and so that patient example was very important to me because while I do a lot of virtual things, there is something about laying on your hands on a patient. You can't diagnose an ear infection virtually well. So how does that work? Are there templates? So if they had chosen the virtual visit, but then some of the templating is like, this is going to be better for an in-person visit. And also the value base, the current value base in pediatrics is only vaccines. And so who would decide what is the value-based care?
Right, good, two great questions. The first is an actually easier answer that this whole solution doesn't go into really changing the way anyone practices. So ideally it's first through value-based contracts with groups of physicians, but even in an open network, we wouldn't change any practice scheme. So if you started with an online visit and the doctor wasn't comfortable diagnosing anything, you'd still go see the doctor in person. And then wait, what was the second question? Sorry, I got too caught up in my first answer.
It's more what are the value-based markers, because the current ones that insurance is listing for pediatrics, because that's where I am at, is only vaccines. That has nothing to do with education, healthy lifestyle, and all of that. So that was my other question.
Okay, so but basically, I think I answered part of it, that it's through existing value-based contracts. So it would depend on which network is being partnered with here.
Thank you, Dave. I think we're running out of time, but everyone, Dave is an amazing developer too. So whatever he showed you, he can do pretty much whatever you want. It can sit on Charm platform or any other thing you want. So he can also do things while he talks. So talk to him after.
Yeah, I can juggle too. So
yeah, he's a fantastic developer. So thank you, Dave. Appreciate your time.
Great, thank you.
Okay, now the next one on the deck is Chuck. Chuck, are you ready?
Yes, I'm ready.
All right, Chuck.
Let me see if I can.
Yeah, while we are getting ready for Chuck, Chuck is also an amazing developer, and he has his own company, and he's going to talk about what he has done with Charm and the amount of integration he has done. This is a very classic look. If you want to see what all you can do on a Charm platform or any other platform, not just Charm platform, he can give you a flavor of what all you can do on the front, and you can imagine he can make a lot of those customization and interact with the Charm APIs.
Thank you, Venki. So as he said, I'm Chuck Krutzinger. I'm the CEO at Countermind, and we offer a point of care data collection mobile app called Mobile Intelligence Clinic. And with that, I'll jump right into the presentation. So today, as we know, healthcare doesn't just happen in clinics and in hospitals. Encounters can happen all over the place, especially in situations like we're facing now with COVID. So while it can be in a clinic, it could also be at the curbside. It can be in homes. It can be in nursing homes. There are mass vaccination events in stadiums. There are health fairs going on around the country. So care doesn't just happen in nice settings. It can be forced to happen anywhere. In fact, one of our clients, or one of our customers who purchased our product is using it in Guam, the health department for Guam, to go into remote villages where there's no computers, no internet, no cell phones, essentially, to gather patient data using this technology. And they're able to sync it back up when they're back at their facilities with full connectivity. And that's important because the data that needs to be collected needs to be detailed, it needs to be accurate, it needs to be secured. And these things can, this data then has to make its way into electronic health records. And in the case of vaccinations, one of the really important things in addition to the health record is the immunization registry. And this technology, I want to take a moment to explain, came out in 2009, or came after 2009, from a discussion with Denver Health. Dr. Art Davidson from Denver Public Health approached Countermind for our mobile technologies, asking about a way to prepare for the next pandemic because of how it had gone for them. In the H1N1 pandemic, Denver Public Health was doing mass vaccination campaigns at the Coors Field parking lot, among other places, where there were long queues of people. They collected mountains of paper forms and were saddled with a mountain of data entry to get that data into immunization registries and health records after the events. And he said, there's got to be a better way. And we began putting something together to address the challenge he threw down. So as we've covered, there's just so many different places and ways that healthcare can be delivered today. And you can use paperwork, but there are some serious downsides. For one, sometimes when you get done with an event and you go through the paperwork, it can be illegible, there can be handwriting errors, there can be lost papers that have personal health information on them, and that can result in HIPAA fines, for example. Paper is one of the least secure ways to be capturing patient data and can become burdensome. And then you can end up with voluminous data entry after some big events. And so we particularly with our technology targeted mass events like public health events, like mass vaccinations that are going on today with COVID. We were targeting how to get lots of detail, lots of accurate information, but in a way that's not burdensome to the healthcare provider, but flows with the event, flows with the encounter. So the solution we came up with, we call Mobile Intelligence Clinic, which I'm just from here on out going to call MI Clinic for short because it's a mouthful. It is a mobile app, runs on iPads, and it's used at the point of care, wherever that may be. And as we've talked about, that can be in the home, at the curbside, in the nursing home, or anywhere. It has customized workflows that we have a technology for, without modifying the app itself, being able to deliver new workflows to the app and have those flows be something, I would compare them to wizards in a lot of Microsoft products. So they line up with the natural flow of the action that you're performing. So if you're doing a vaccination, it flows with collecting the patient data, their insurance data, answering screening questions, and then administering the vaccine and getting all the data there is to know about that vaccine. Like not just which arm, but what was the lot number, what was the expiration date, and things like that, but doing it with a minimal of data entry and typing on the mobile device, using barcode scanning or pre-configured lists that you just tap and choose the correct answer. It's also done in a way that gives you integration with the EHR. We recently, this past year, integrated with the Charm EHR at a customer in California. And it also has to have a multi-layered security. So we've taken that challenge into our product. So we use it within the mobile device. We've got the layers of security provided by Apple themselves. They offer a way to encrypt the entire, they call it sandbox that the app lives in. So every file saved within that sandbox is in an encrypted setup that Apple controls the encryption to. And then we save those files in an encrypted format within the encrypted sandbox to provide an extra layer of security. And then all our communications over the internet are encrypted, of course, end to end, without any means to for a third party to crack. Well, not without any means, but with a highly secure. And then we've done it all in a way where the iPad can be disconnected. It can work connected and everything will be synced up instantly, or it can work disconnected and sync up in batch after an event. Specifically talking about the Charm EHR, we have a number of integration points, starting with patient demographics. So we're able to get the name and address and contact information, age, ethnicity, and race, phone number, email, all those data points. And we do that first off with a barcode scan of a driver's license, if that's available, which will populate most of what I just described. And then a few taps to gather insurance information and other things. It then creates the encounter in Charm, populates that encounter with all the data from the event. It populates a screening questionnaire into Charm so that those can be looked up and confirm the answers and printed out later. It passes on the vaccination data to Charm. And Charm, in this instance in California, in turn relays that vaccination data into the immunization registry for California. The integration between MI-Clinic and Charm also passes on, creates the invoice for the encounter, passes on the payment information if a payment was made at the time, or if it's an insurance claim, it will generate the claim. Charm actually generates the claim, but MI-Clinic passes on the data necessary to do it and triggers it. As far as a mobile app, Charm has, I believe, has its own mobile app as a part of their suite of options, and it's a mobile app for accessing the wide range of Charm functionality. But in contrast, MI-Clinic is a specialized app with these specialized wizard-like processes for the encounters. That does a lot of things to streamline that encounter, not only taking you through this wizard-like flow, but barcode scanning driver's licenses, barcode scanning vaccine vials and vaccine information statements to collect data off of them. This back end where we can formulate questionnaires and treatment data that we want to collect and pass that to the mobile app so that the mobile app is updated without any software updates. And then while we are aware of various EHRs that have mobile add-ons, we're not aware of another standalone product that fits the description of ours of having this optimized point of care data collection capability. In terms of technical viability, it's already up and running. It's been up and running for about 9 months. In fact, in California, they've already had more than 20,000 patient encounters populate into Charm using this technology. I pulled that information just yesterday. And as I said, it uses all these listed APIs to get that data into Charm. And so really, it's an up and running solution as of today. And then, about us, Countermine is not new to the mobile app space. In fact, we've been at this for just shy of 20 years. And for the last 8, we pivoted to focus exclusively on healthcare-oriented technologies and solutions. This is our flagship product, the Mobile Intelligence Clinic. Countermine is a founding member of the Catalyst Health Technology Integrator in Denver, a real hub for health technology innovation. We have a patent on our workflow technology that's part of our product. And we were recognized with an award from the National Association of County and City Health Officials as a model practice for mass vaccination campaigns. And today it's up and running in 5 different state health departments: Connecticut, Delaware, New Hampshire, Nevada, and South Carolina. as well as 3 Pacific Islands. I've already mentioned Guam, but in addition, Marshall Islands and Federated States of Micronesia are also using it for their health departments. Denver County Health Department and Central Coast Visiting Nurses Association in California. So, you know, the bottom line, we feel MI Clinic provides a secure way to collect detailed patient care data in settings ranging from clinics to curbside to homes to even remote island villages. And that data is captured and then fully integrated with the EHR, providing a complete, accurate, detailed record of the care that was provided. And with that, I finished a little early, so we have time for some questions if there are any.
Thank you, Chuck, for your time. I appreciate it. This is a good presentation. And as I said before, you have done the whole piece, and we don't have time. Otherwise, you can show them the whole workflow and what all it can do. And thank you for your time. A couple of things. I think I'm not seeing any questions here on the chat. So how do they get hold of you, and what is your next project?
We are at countermind.com, and we are working on some new features to MI Clinic. We also have for those interested, we have I guess I consider it kind of a hobby app that's out there used for organ donor registration. I'm a living donor, donated my kidney to a good friend 5 years ago. And we have an app that makes it easy for the organ procurement organizations around the country to go out and register people by just scanning the driver's license using smartphones and get those people registered into the national registry or their state registries.
That's very interesting. Thank you so much for that information.
You bet. Thanks for inviting us.
Thank you, Chuck. Have a good one. Thank you. Okay, now we are going to a break now from 3:20 to 3:30, and then after 3:30 we'll start the session again. So a 10-minute break. Aarti, are you there? So
Yes,
we'll
sir.
pause for 10 minutes.